Earned his doctoral degree in computational biology and biostatistics at Harvard University. After graduate school, he continued research at NIH and earned an MD at the University of Michigan. He has an unusual experience as a primary care physician in San Francisco. There, the complexities of chronic pain, its diagnosis, and its management led him to pursue a career in pain medicine, and we're very fortunate to have him in the clinic. He believes the best approach to chronic pain is both scientific and patient-centric. And I would just like to add, he is an assistant professor at Stanford, and he is the associate chief of clinic operations at the Stanford Pain Management Center. And it looks like you've got your talk up. So please join me in welcoming Dr. Kao.
Does the screen extension? F5. And then which one? The projector is these. Which one switches the projector modes?
A brain tumor, Parkinson's, epilepsy. They can impair the nervous system and disable normal function. But here at Stanford, our neurospecialists are finding ways to address the damage and restore activity. Through innovative techniques like rerouting circuits in the brain, we can often recover function that once was lost. For a patient, it's like a miracle. For us, another door opens.
Discover more at stanfordhealthcare.org.
Okay. Well, thank you. Sorry about that. I always had a little technical issue with PowerPoint. I felt strongly about using my own laptop because I spent a couple of nights working on a very cool movie I'm going to show you later. So I'm very proud of it. So I'd like to take this opportunity to talk about the proper role, perhaps, of medications in chronic low back pain. Now, as Dr. Darnell had mentioned, I used to work as a primary care physician in San Francisco, and now I'm a full-time clinician at the Stanford Pain Management Center. And I see a lot of patients with chronic low back pain. I have strong feelings about it. I'm very passionate about helping patients with chronic low back pain. I'd like to share some thoughts with you today. First of all, no disclosures. So as far as chronic low back pain, and medication use in this condition, today I'm going to start by talking about a problem. As in, I think we as a society, not us, not you, but we as a society together have found ourselves in trouble when it comes to medication use in lower back pain. I'll describe why that is, and I'll offer a solution. In fact, it's a solution that should not be surprising to you because you have heard it, starting from this morning, from all of our pain specialists. And I'll come back and talk about those solutions. And finally, I'm going to turn around, instead of the insider's view on chronic low back pain, take the perspective of patients and offer some tips on medications in chronic low back pain. All right, so this is what I think of when I think about medication use in chronic low back pain. On a society level, right, this is a big sinkhole. And I think we together, as a society, have found ourselves in trouble. And this is the kind of hole we find ourselves in. And for the next 10 minutes or so, I'd like to describe why I think this way. And I will offer a solution at the end. So as Dr. Ming-Chih has said this morning, chronic low back pain is the most common chronic pain condition in the United States. The 28% figure that Dr. Ming-Chih has cited is replicated here. This came from a nationally representative survey performed by the CDC. And it found that among adults 18 years or older, civilian non-institutionalized population, about 28% of them reported chronic low back pain lasting more than 3 months. Now, 28% is just a number. Exactly how big is that? So if we asked all the patients with chronic low back pain to move westward, to move towards California, a couple of things would happen. First, our housing prices would get even more amazing. And second of all, it's going to overfill California. Actually require 28% of the US population is going to fill California, Oregon, Washington, Arizona, Nevada, and New Mexico. That's 66 million. That's 28% of the United States population. And that is a significant number. That's 1 in 4 Americans. Compare that against the number of primary care physicians in the United States. There are only 400,000 primary care physicians actively practicing in the United States. That's half of the San Francisco population, only 400,000. So if you divide those two numbers, you'll find that each primary care physician is now responsible for, on average, 165 patients with chronic low back pain. Does anyone have any idea how many patients a primary care physician would see? It's about 800 on a typical practice, up to 1,500 or 2,000 in the more aggressive practices, and 165 will constitute a significant portion of that. And not only do we see this happen in increasing proportions with patients with chronic low back pain, when the CDC calls them, we also see that the patients show up at primary care clinics more and more so with chronic low back pain. This started at about 2.5% in 1997, and now is about 5% of visits in 2009. So by one measure, I wanted to describe a problem. So by one measure, this is a big problem, just by virtue of its size. Just by virtue of its size. And here's the other very cool movie, I hope it's coming through. All right, so this is our lower back, and these are all the important anatomic structures that we know of in medicine in the lower back. And I'm almost amazed because each month when I open up the journals, there's always a case report or two describing yet another way to explain low back pain. Perhaps another anatomic structure is involved, and perhaps that could cause someone to have low back pain. And it's altogether highly complex of a problem. There are just categorically different ways of explaining low back pain. It could be neuropathic, arthritic, discogenic, inflammatory, myopathic, or ligamentous. And there are hundreds of ways to explain low back pain. And so therefore, our job as clinicians is, first of all, to figure out if there are important diagnoses that explain the back pain, tease it out, and help the patient with it. This will involve clinical history, quite involved, reviewing of records, performance of significant number of diagnostic studies, including, and I have to imagine many in the audience have had things like X-ray, MRIs, CT, each of which would reveal different aspects of the lower back or other ways of explaining chronic low back pain. And what's important, I think, for our patients to realize is that this is highly complex, and it does take time to go through these diagnostic studies. It does take time to synthesize the data. At the end of the day, we may not have a black and white answer. And oftentimes we find ourselves as a field and as clinicians and patients having to go through a series of therapeutic trials where we try different medications, where we try different interventional procedures. And I mention this because I find this is important for patients to understand. It does take time when it comes to a medical approach to chronic low back pain to tease things apart and to find the right solution. So the complexity, that's the second dimension of this big problem we're facing. So finally, I would like to demonstrate that back pain treatment is oftentimes misunderstood. Back pain treatment with medication, I should say, is oftentimes misunderstood. Has anyone here ever been offered medications like hydrocodone oxycodone. Yeah, so this is oftentimes taken as perhaps a first-line treatment for chronic low back pain. You can see the data from the CDC in the charts. The more and more patients are getting opiate medication prescriptions at primary care clinics around the country, from about 20% in 1999 to about 40% in 2009. So that's about a doubling of the rate. So many patients like you have been offered opiate medications like hydrocodone, like oxycodone. So I guess the question is, so what? Why is that a problem? Well, even the opiate medications are really great medications for acute issues, like after a surgery, like after a fracture. We have found in scientific studies, more and more so, each and every month, we're finding revealing really issues with the chronic use of opiate medications for pain in general, and perhaps even more so in chronic low back pain. Some of these side effects or adverse effects are very well appreciated, like on the left-hand side, things like constipation, things like sedation. Other adverse effects are not so well recognized, and I'd like to just take a little time to go through each and every one of them. Okay, so starting from the top is a phenomenon called tolerance. Tolerance is where the body, after having been exposed to opiate medications, is now so used to it that the same dose of opiate medications that were given before are no longer effective. And the patient needs larger doses to achieve some type of additional pain relief. And I see heads are nodding in the audience, a very, very common observation. And what I see in clinic is patients will end up in this cycle of dose escalation, increasing their dose, develop new tolerance, increase the dose again, develop new tolerance. It's an endless cycle. And it's a cycle that we like to avoid. Another observation is a mechanism called physical dependence. This is where the body, it's a flip side of a tolerance, where the body is now so used to having opiate medications that suppose you reduce the dose or suppose you skip the dose, the body basically reacts against it. Patient feels uncomfortable, patient starts having withdrawal symptoms, and that's an unpleasant state patients find themselves in. Okay, so there are several other now very well understood, appreciated adverse effects like increased risk of fall, problems, this is secondary to the sedation, dizziness, and a decreased, prolonged reaction time that comes with opiate use. Patients are more likely to get into car accidents. This is studied much more so in Europe than in the States. But they have found patients who are taking opiates long term, taking large doses, may place themselves at risk on the road. There's a risk of drug interactions. Many antibiotics and many sedative medications can interact with opiate medications, placing patients at risk. And two, very important, and I really need to emphasize this, adverse effects of chronic opiate use is reduced immunity and reduced hormonal function. So reduced immunity means your cells, your immune system, does not react as well as it should to infections, placing patients at greater risk of infections. And altered hormones typically involve the testosterone and estrogen, and patients on large dose opiates will complain of things like erectile dysfunction and sexual dysfunction. So, thanks for your patience. I really wanted to go over that list because this is the important aspect of misunderstood part of medication use in pain management of low back pain. So in contrast to that, there are really only about 20 opiate medications in pain. We in the pain clinic work with about 207 medications. So opiate medications are just 10% of what we do. And there are many other non-opiate medications that are oftentimes overlooked by other providers. These would be things like neurotransmitter medications like duloxetine, gabapentin, pregabalin, other nerve medications, muscle medications, anti-inflammatory medications, and hormonal medications. Each one of these is a good alternative to opiate medications, and when we work with patients with chronic low back pain, because of all the side effects we went through earlier, we like to avoid the use of opiates and then optimize their non-opiate medications, like these I've listed here. So there should be about 200 medications. Okay. So there should have been about 200 medications flying through the screen just now, but maybe it flew by too fast. We didn't see that. Okay. Well, it's okay. In relation to that, how complex is pain medicine? I just want to take a few minutes. This is a very interesting. This is what I do. This is what Dr. Mackey does in terms of pain medicine, and we find it fascinating when we start cataloging how complex our field really is. We're working with, for example, 108 important muscles of the body that contribute to pain, 70-some nerves that can contribute to pain. There are lots of psychosocial factors that contribute to pain, about 400 different diagnoses we need to work with, and finally choose from 200 medications and 230 different interventional procedures. Altogether, if we really counted it, the number of possible medication regimens is about the number of atoms in the universe. It's something we can handle at the pain clinic. Yeah, sure. Okay, so we have now described what I believe is a hole our society has found ourselves in. We know chronic low back pain and its medication use of this condition is a big problem by virtue of the size, by virtue of the complexity, and by virtue of the misconceptions that are out there. So it's a big problem. So how do we overcome this? Well, if we're in a hole, do we keep digging, or should we somehow climb out of this hole? So again, really the solution is right there in front of you. The solution you have already heard, starting from this morning. That is the solution. That's the simple version of it. Actually, this is the solution. That was the problem. Now here are the solutions. These are all the things you heard about this morning and this afternoon. Right. Non-narcotic medications, meditation, cognitive behavioral therapy. We identify parts of the pain cycle that are affected in all patients with pain, in patients with chronic low back pain. We target those areas in a team approach, and we help patients with pain. This is the solution to medication use in chronic low back pain and multimodal pain management. Another aspect of this is to realize, remember earlier when we talked about physical dependence, it's very hard, even though I understand and patients understand opiate medications cause problems, it is sometimes quite hard to come off of opiate medications. And it's a problem that's well understood by us. We have a lot of experience working with patients with this issue, and we have developed specialized programs for it. And this, just like earlier, is going to be interdisciplinary. It's going to be physicians, psychologists, physical therapists. We work with patients who are, shall I say, stuck on these opiate medications, by optimizing their non-narcotic medications, gradually reducing their opiate medications, and managing their withdrawal symptoms. We even have an inpatient program that's in hospital. It's intensive, about a week stay, where we help patients reduce their opiate medications and plug into an intensive interdisciplinary pain management program. Okay, so that was my insider's perspective on the medication use in chronic low back pain. I'm going to switch gears a little bit and just take a step back and offer some tips on medication use from a patient's perspective in chronic low back pain. I need to note that I'm very happy to be here to talk about a topic that I feel very strongly about, but ultimately I need to say that this is not medical advice. I am talking in generalities today, and if you plan to make any changes to your medications, I would advise that you chat with your physician, and everyone's entitled to a second opinion, and we're available at Stanford Pain Management Center as well. All right, so the 4 tips I'd like to discuss is, first of all, many patients have this concern that pain medicines will hide their pain, therefore causing problems. The second concern patients has about side effects. That's very reasonable, and I'll discuss that a little bit. Third is about how medications work and what are their effects. And this is a little bit subtle, so I will take some time to talk about it later. And lastly, I always remind all of my patients to do not forget other aspects of their health. Do not forget other aspects of their health. Okay, so first of all, do pain medications really hide the pain, therefore causing problems? Patients who say, well, what if I cannot detect some type of tissue injury, therefore causing more problems, and this could be catastrophic? The thing I'd remind our patients is that non-opiate medications are excellent, but they usually just reduce the pain level and do not remove pain. There will still be pain sensation that can be protective in nature. So the question now becomes, if it doesn't remove pain, why do we even take it? Why bother paying for the medication, setting an alarm, taking the medication on a daily basis if it doesn't remove pain? From pain medicine's perspective, it is actually very important to reduce pain signal. As Dr. Mackey had mentioned earlier today, in a process called central sensitization, and here's some animation. There we go. All right, so on the top is a normal nerve transduction from the left to the right. On the right is the brain and the spinal cord. And we send one signal over to the brain and spinal cord, and that's a normal state of affairs. But if you have an extremely active nerve that keeps sending signal to the brain or the spinal cord, our brain and spinal cord learns, like we do on a daily basis, it learns about pain too. So over time, this repetitive trains of stimulation coming from the nerves causes changes in the spinal cord and the brain, and therefore causing chronic pain. And that's a pathological process. It serves no protective role. And that process called central sensitization is something we would like to help patients with these non-narcotic medications, the non-opiate medications. So it does not hide pain and reduces central sensitization. Another aspect of this that's very important is that we like patients to participate in the solution we talked about earlier that involves psychology, meditation, cognitive behavioral therapy, physical therapy, home exercise program, acupuncture. We like to help patients participate fully in each and every one of these modalities. And therefore, by reducing the level of pain that they experience, they can participate more fully and therefore get more benefit from these modalities. All right, we talked about how pain medication does not hide the pain. Now I need to talk to you about side effects that come with non-opiate pain medications. Now, every medication will have its unique set of side effects. And I'm always amazed at the clinic because on a daily basis I will hear about unusual reactions to otherwise very common medications we use in the pain clinic. And this is because everyone just built differently. There are 3 billion 3 billion base pairs in the genome, and each one of us is different. We all react differently to the medications. So where does that leave us? We're not at the stage yet we can predict side effects based on the genome. I think Dr. Mackey is working towards that with several projects at Stanford, but we're not there yet. So we take an empirical approach and practical approach. We start medications at a low dose and we increase it slowly. And we ask patients to pay attention to any side effects they might experience. And we react to it by either not increasing the doses fully, react to it by changing to another class of medications. It's also important to know that these non-opiate medications, in terms of their prescription, must be individualized. At the pain clinic, there is a very popular medication that just so happens to be FDA approved for weight loss, for example, and then some patients really like that. And other medications will cause weight gain, and just depends on the patient's situation in our medication choice. Okay, we talked about medications do not hide pain. We talked about the side effects and the individuality when it comes to side effects. I'd like to talk a little bit about the effect of non-opiate medications. I assume most of you in the audience have taken antibiotics before, right? And most of you have taken blood pressure medication. Well, many people have taken blood pressure medications. And what's different about these two medications? Well, antibiotics are taken just for a few days to a few weeks, and you take it until we know the infection has cleared. Right? It's meant for an acute and limited episode. Blood pressure medications, on the other hand, where we know hypertension is the silent killer. Blood pressure medications, on the other hand, need to be taken on a regular basis, for the most part, regardless of the blood pressure. It's taken to protect you. And chronic pain is in many ways analogous to hypertension. It is a chronic condition. And medication used for chronic low back pain are often taken like blood pressure medications, as in we would like to, as we discussed earlier, reduce the signal going to your brain and spinal cord, and we would like patients to take many of these medications on a scheduled basis. This is in particular the case for the neurotransmitter medications. Recent research in brain research have found that on a daily basis, we generate new brain cells. But on a daily basis, many of these new brain cells do not incorporate into the brain and they die off. But what we have found in the use of neurotransmitter medications is that they promote the survival of these brain cells. More of these brain cells that are born on a daily basis will now be incorporated into the brain. So not only do we get smarter, our mood is better and our pain is less. And that takes about a month to actually work. So that effect takes about a month to actually work, whereas the side effects of many of these medications will be manifest in day 1 or day 2. So this is why it is important to work with your physician and be a little bit patient for the effects to really kick in. All right, so lastly, this is a very important point. Just do not forget about the fundamentals. The circuitry of the brain is built such that pain signal is the most prominent and most salient signal of them all. And unfortunately, for many patients suffering from chronic pain, the signal is so overwhelming that they overlook other aspects of their health. I think there was a patient who missed a colonoscopy from year to year for about 30 years. But this is an important part of their healthcare. Then they neglected their blood pressure, neglected their diabetes. These are all not good things to happen. And that list are all, it finally worked, by the way. So that list are all the preventive services recommended by the Agency for Health, Research and Quality, the ARC, that patients are supposed to undergo. So as a last point, please don't forget the other aspects of your health as we focus on the chronic low back pain. All right, so in summary, we talked about how medication use in chronic low back pain is a little bit problematic because of its size, because of its complexity, and because of misunderstood nature of many medications in chronic low back pain. We talked about the solutions, some simple, some not so simple, but all involving multimodal treatments, as you have been hearing today. We talked about the 4 tips for non-opiate medication used in chronic low back pain, starting from the fact that they do not hide pain. We talked about how the individuals will have very individualized side effects to the same medications. We talked about how many non-opiate medications have an effect by inducing the body to change, not by the medication itself, by inducing changes in the body. So therefore it takes time. Therefore it requires patience. And lastly, the last point, just don't forget about other facets of your health. And I guess just the very last thing that we are dealing with, the number of atoms in the universe when we choose medications. So, all right, thank you.